A lot of familiar faces here. Yeah, it's great to see everybody again in person for these wonderful events. So I'm not sure. Are we sort of live or starting?
Well, the live meeting has just started. Welcome everyone to our first Ask the Doctor discussion of 2024. My name is Melanie Wiedmeyer, and Mickey is also here today, as many of you know, and she's wanting to retire, so I'm kind of here hoping to fill her shoes. And so yes, so we welcome Dr. Matthew Pianko today, and he's with the University of Michigan, works out of the Global Cancer Center, and his focus is patients with multiple myeloma, as you know, as many of you know in this room, and we are thankful for your time and efforts today to help us out and learn more about this important topic. I asked any in the room that have a mobile device if you could please mute it. And those of you that are on the Zoom meeting, could you mute yourself? And when you want to ask a question, then please unmute yourself and ask your question. There's also, if you're uncomfortable with talking, there is a chat button on the bottom toolbar for those of you in Zoom to enter your chat there, your question there, and I'll ask it of Dr. Pianko. All right. Well, I'll let Dr. Pianko start. Tell us a little bit about yourself and what you're up to these days, and if there's anything new and enlightening before we open the floor to questions.
Great. Well, thank you all for joining for another one of these wonderful Breakfast with the Doc events. I always really enjoy getting to meet with all of you and talk about what we have going on at U of M and what's new in multiple myeloma. So look forward to an engaging discussion this morning. So thanks to those in person who are here, and thanks to those on Zoom. So look forward to having a great discussion this morning. So I'm a clinical assistant professor. I've been at U of M about 5 years now. It'll be 6 this fall. And largely my efforts since being at U of M have focused on the care of patients with multiple myeloma and other plasma cell disorders. And we've been pretty active in clinical research and clinical trials, and have been trying to bring the cutting edge of treatments to our patients here in Michigan, and have been engaging with a number of different groups like the Multiple Myeloma Research Foundation, and recently taken a role as one of the co-chairs of our Big Ten Multiple Myeloma Cancer Research Consortium working group. So active both here in Ann Arbor and kind of across the country, and I've really enjoyed my role here. It's been really nice being back in Michigan. I was an undergraduate here and then left for my medical training, and then came back, and I've got some family connections in the area, and it's been really nice to be back in the Midwest. So that's just a little bit about me. I think I'd be happy to talk. I think maybe we can start with doing some questions, and I think then we'll probably cover a lot of what I imagine is going on in research in myeloma. What some of the exciting things I think most recently have been some of the new immune therapies that have come out for myeloma, and we're having a lot of new tools in our toolbox. They are complicated, and there are some challenges in using them. So in learning how to maximize the benefit and minimize the side effects, we're learning how to do that. And I think there's a lot of exciting advances to come for treatment of multiple myeloma patients in the near future. I think it continues to be a rapidly changing field with lots of new things happening, which is one of the reasons that I was drawn to this area. So
we do have our first question via chat. A few years ago, you mentioned studying gut microbiota in myeloma, and wondered if you were still doing that, if you could expand on that research.
Yeah, happily. Well, thank you for the question. So we are still I am still interested in this and working on this. So what we have had, so the gut microbiome, I think it'd be important for us to kind of talk about what that is. So the gut microbiome is a term that describes the community of bacteria and other microorganisms that live in us and aren't necessarily harmful, but maybe are have like a symbiotic relationship with us. So they exist with us, they contribute to our health and well-being. There are certain conditions where if the microbiome can become altered, either through maybe antibiotic exposure, it can disrupt the microbiome. There can be negative health impacts in some cases. So one of the probably the most well-known ones is, if someone gets antibiotics to treat a certain infection, they might be at risk of developing another type of infection called C. diff, which can cause some kind of bad diarrhea. And essentially this bacteria C. diff is resistant to certain antibiotics. So if you clear out all the good bacteria, this bad bacteria has the chance to kind of expand. And so there have been some treatments directed at C. diff where you can choose antibiotics for C. diff. There have also been ways of trying to replace the good microbiome by giving patients this sounds, well, kind of gross, but stool transplants. So taking stool from a healthy donor, screening them for illnesses, having like a capsule that has live, bacteria in it that can kind of replenish the normal bacteria throughout the gut. So why is this important? How does this impact myeloma? So when I was a trainee at Memorial Sloan Kettering, what we did was looked at trying to study the microbiome in multiple myeloma patients. Why are we interested in this? So there were several studies that came out in other types of cancer where the gut bacteria seem to be important for responding to immune therapies. In patients with melanoma who were getting drugs that made the immune system recognize and fight the cancer, we found there were findings that the gut microbiome was important for this response. So we wanted to look in myeloma patients to see if this was the case in multiple myeloma patients. Now, the same types of immune therapies that are used in melanoma are not used in myeloma, but the way that we wanted to approach this was to look at patients with multiple myeloma who had finished their initial therapy. So they'd gone through their induction therapy, which maybe is the 4 to 6 months or more of initial multi-drug treatment. Some of these patients had gone on to get an autologous stem cell transplant. And essentially we took a trial of lenalidomide maintenance for myeloma and added stool samples to it. So patients who were starting the trial would collect fresh stool samples. We would freeze them along the way. And essentially my project found that, so what we looked at, another thing that was built into this trial that is important, was an important part of the trial is something called minimal residual disease testing, or MRD. And so we wanted to, we overall had a group of patients who had finished their initial treatments for myeloma. Some were in complete remission, some were not quite in complete remission, but had responded. So we had MRD results for all these patients. So we collected stool samples, we knew their MRD status, and I asked the question of whether or not there was a relationship with the gut bacteria contents and whether patients were able to get to MRD negative. So whether or not the myeloma was eliminated to the best we could detect with our tools that we had. And we found that there were some interesting findings that there were certain bacteria that made a type of byproduct that was a breakdown of dietary fiber. And this byproduct, which was called butyrate, is good for gut health. It seems to also be important in affecting the immune responses. And so we found in this group of small group of patients, probably about 34 patients, that there were certain bacteria that were more abundant in the people that had superior responses to treatment. So that was probably the first study that looked at microbiome in myeloma patients. There have been some other studies of the microbiome and how it impacts the development of multiple myeloma in like a mouse model of myeloma. And this was also, I think, an interesting finding that there are certain mouse models of myeloma where the mice will spontaneously develop myeloma. And there was they've been genetically altered in a way so that it promotes the ability to develop myeloma. And it's been used to study all the myeloma drugs that we have in use today. Many of them have been used in this. It was developed by Dr. Bergsagel at Mayo Clinic in Arizona. He's at Arizona now. He was at other institutions prior, but essentially they found that the mice, these mice, this colony of mice has been used in labs across the world. And so they found that there was a group of, they found that the rates at which the mice developed myeloma were different in different places. And so there was a colony of the mice in New York, there's a colony of the mice in Italy, and for some reason there was, the mice are genetically identical, but they developed myeloma at different rates, which was an interesting finding. So ultimately, they ended up studying the gut microbiome and found that there were certain bacteria that were more abundant and potentially implicated in driving the development of myeloma in the mouse model. So I think the take home from both of these is that there's at least some interesting preliminary information that our gut bacteria might influence the biology of myeloma. How does that happen? So, gut bacteria and the contents of the bacteria can influence the amount of inflammation that we might have. So we found in the mouse model that there was some more, this bacteria they found was associated with more myeloma development, made the mice have more inflammation in their blood. And that was, not to get too in depth with the science of it, but they found that the inflammation that was caused by this bacteria led to more myeloma growth. So, how does this impact us? Like what to do next? So there have been some other studies from my colleague, Dr. Urvi Shah at Memorial Sloan Kettering in New York, that have looked at the impacts of the diet. So she's been studying the dietary, she's had a few studies of like plant-based diets for patients with precursor disease to myeloma, smoldering multiple myeloma, and MGUS. And have also found some interesting findings. So she had the study that I started, and those stool samples that I collected when I was at Memorial Sloan Kettering were studied by Dr. Shah, and they measured this like compound that we thought was important, and found that the people who had been eating more plant-based diets had more of this good bacteria byproduct. So, how could that? I think she's got a really interesting portfolio of research and a bunch of YouTube videos that I think are fascinating. So, Dr. Urvi Shah is her name, URVI SHAH. She's got a bunch of YouTube videos, and you could probably look her up online to explore kind of some of the impacts of diet on myeloma, which I think can impact the microbiome. So, what to step back to say, what are we doing now? So at U of M, I've had to find the tools to get all the operation going to collect stool samples and get them from the patients to a freezer. All of that infrastructure existed for me in New York, and it was easy to plug into something that already existed. I've kind of had to create my own pathway for that here. So we have just started doing that. We've had some of our patients collect stool samples that can be mailed back to us. And one of the things that I'm very interested in looking at is the potential impacts of some of these our gut microbiome on some of the immune treatments that are coming out now. So really interested to see what might be the impacts of the microbiome on either CAR T cells or on some of the bispecific antibodies to see if there might be some relationship there. Yes, I was a question in the room.
You select for your study, do they have to be active myeloma patients, or could they be SCR patients?
At this point in time, we don't have strict criteria about who we're selecting. So I think that the patient could be in a stringent complete response. The question for those on the chat was whether or not there was a specific group of patients and that we were choosing for our microbiome studies. At this point in time, no, it's more observational, and we're getting the process going. I think what's important to communicate is that at this point in time, the science of microbiome analysis is not at a place where we can make clear recommendations based on our microbiome testing. So I'm not going to get a report for a particular patient to tell a certain patient that, oh, I think you're low in this bacteria. How about we do something to make it better? So I think that at this point in time, we're really trying to gather information. I think it's definitely of interest to look at patients in all disease states, whether or not they're in complete remission or whether they have active disease. I think there's something to be learned about this area. There's a lot more to be learned about this area, and I think that we're not being very strict about who we're including or not including. Really, collecting stool samples, not everyone's most enjoyable activity. So, I think when I discuss this with patients, people have a different response to the question. So not everyone's willing to collect stool, but I think it's a fascinating area. And
Are they volunteers or are the doctors suggesting that they participate?
I in my clinic have been approaching patients who are in my clinic to ask if they might be willing to contribute stool samples, and it's they're consenting to a research study which allows us to collect tissue samples from the patients, which we've had open for many years now, and they'd be volunteering as research participants. But
In my case, Dr. It's never come up in discussions with Dr. Pianko.
yeah, it's pretty new, I would say. I've been it has not been a straightforward process to build the pathway, which is why I'm not sure how many years ago I mentioned this. I've been interested for 5 years. It's taken a long time. So I'd be happy to discuss that with you and with Dr. Campagnaro. Really, I think the process has been open for really the past few weeks, the most current process. So I've just been working. I haven't really included Dr. Campagnaro yet because we're early in the phase of, but at this point in time, we certainly could. Yeah.
So that question was from Mary Nora, and she's follow-up saying awesome information. She thanked you, and she said that she's been hearing that the more diverse the gut microbiome with plant-based materials, and that the longer the progression of myeloma. It's a great point. So I think that gets to what is important about the microbiome. So I think that maintaining a healthy gut microbiome, which means you have a good diverse group of bacteria there that are from all the different subspecies of bacteria, can contribute to ways in our health and well-being that we don't really even completely fully understand at this point. But we know from there's a lot more data that have already been collected, and really from the transplant literature, from the allogeneic transplant literature. So at Memorial Sloan Kettering, where I trained, there was like an effort to collect over 10 years stool samples from basically everyone that was getting a transplant, and they built this whole mechanism of collecting stool from like all the patients who were admitted for transplant. And they have a huge database. And I think from that database has come a lot of discoveries about looking at, the health of the microbiome and potential negative impacts for some of these patients. So they found that when the gut microbiome was not diverse, so when the gut microbiome was dominated maybe by one type of bacteria, sometimes that led to increased risk of infections. They also had found negative impacts on outcomes. So potentially, for some of these patients, had increased risk of disease relapse of their blood cancers by having a decreased diversity of their gut microbiome. So there are really, I think, potentially interesting implications for this for patients. I think that the last point that I'll make is some of the epidemiologic literature there's a paper that looked at dietary patterns in people with precursor disease. I think it was I can't remember, it was a European or Swedish-based study, but they looked at and found that some of the patients with precursor disease who ate more plant-based products or had more leafy greens in their diet there was a suggestion of a lower rate of progression to active myeloma. So I think that it's kind of study touches a lot on like the regional with heart disease, I know, in diet and plant-based diet. And there's one follow-up question to this, and then there's another new question. David asked, do patients with pre-existing autoimmune conditions have a greater risk of multiple myeloma? For example, ulcerative colitis.
Excuse me. So it's a great question. And then we did have a question from Carol in the back of the room, which we'll get back to as well. So what I'll say is so this has been an interesting this is also an interesting question. We get lots of patients referred to us from the rheumatology clinics because in the evaluation of autoimmune diseases, protein electrophoresis can be sent off, and sometimes it detects M proteins. So we sometimes get patients with monoclonal gammopathy of undetermined significance, or MGUS, or smoldering myeloma referred to us from those clinics. And so I recall that there was a study that looked at these group of patients with precursor disease to myeloma and an autoimmune disease. And they found that the patients who had a antibody-mediated autoimmune disease, which means that there was some type of antibody driving autoimmune disease. So maybe an anti-nuclear antibody. There's a whole group of them that have an antibody that is like an antibody against oneself, and that's part of the immune system response to that's driving the autoimmune condition. So they found that people that had an antibody-mediated autoimmune condition had very low rates of progression to myeloma. The people that had non-antibody mediated autoimmune conditions had a relatively higher rate of progression than the standard group of this is MGUS patients. So overall low rates of progression to myeloma, but they found that there was a difference in the types of autoimmune conditions and their risk of development of myeloma. To my knowledge, ulcerative colitis would be a non-antibody mediated autoimmune condition. So there may be a slight, if in an MGUS patient with ulcerative colitis, there may be a slightly higher risk. Teasing out other relationships between development of autoimmune disease and myeloma, I think is challenging. So I think that I don't find that it's a really active risk factor for development of myeloma, but autoimmune disease is common, and we do see a fair amount of it. We see some patients who have myeloma and autoimmune disease. And there may be some interrelatedness, but especially earlier I referenced some of these like gut microbiome studies where they found that some of the inflammation in the blood by this like abnormal or this bacteria could like promote myeloma plasma cell growth. So some of these immune factors, which are called cytokines, which is some part of the way that our immune system communicates with itself. These cytokines are like chemical messages that our immune system uses to work and function. And so it's in theory, autoimmune conditions raise inflammation in the body. People have generally increased amounts of inflammation. Could that promote plasma cell growth? It could. But I think the hard part is knowing at some point, the patients with pre-malignant disease, like smoldering myeloma or MGUS, there's something that changes and then it becomes active. And I think that the hard part is knowing, I don't think we really understand all of the in-depth details of why something flips from a precursor disease to an active phase of disease. So that's, I think, another very, kind of interesting area that touches peripherally on that question. So Carol, did you want to ask your question?
For gut health, is there a specific test that the patients could get to test their gut?
Excuse me. Regularly, no. In our clinics, no. I have had patients who've shown me reports that they've obtained from naturopathic doctors. There's some send out labs where people can send a test to like check the health of the gut microbiome, but I really have a great degree of skepticism for that because there is not really there is not quote unquote a normal microbiome. So I think to some of these reports, I just question, what are the conclusions that are being drawn, and what what kind of information is being returned to patients, like how valid is that? So I don't think there's like, I guess like a validated microbiome test.
Kind of normal
No,
range.
I don't think so.
Okay.
That not one that's, to my knowledge, readily available. There've been some commercial companies. There's some companies that have been, trying to develop stool tests. One of them folded. I think there were some questions about the validity of the company. I think it was called Ubiome. So this is not some. I think it'd be very interesting to have that. And there have been. I would love to be able to have a way for the patients that are in our research studies that I could like show them what their microbiome shows. But the way that our research program works at this point is we'll collect the stool samples. We'll get enough to then do a batch sequence where we send it for gene sequencing, and that tells us all about like what the gut microbiome contents are. It's like what we do. We sequence the bacterial DNA. We run it through a computational pipeline that like sorts it all out and tells us what are the relative amounts of the certain bacterial species that are there. It'd be great to like offer a report back to patients, say, here's what you have. We don't have that right now accessible, but it's a great question.
So we have a question from George. When is the best time to stop maintenance chemotherapy with maintenance Velcade or Revlimid chemotherapy over 2 years, 5 years, or 10 years or longer? Do you have any algorithms to make this decision? He goes on to ask, is it possible to have liquid biopsies from regular blood or serum to find myeloma markers without invading bone marrow biopsies by using mass spectrum?
So great question. What I'll say is, maintenance therapy. Goal of maintenance therapy in myeloma is aimed at prolonging the duration of remission and trying to extend the time between the end of the initial therapy for myeloma and the first relapse. So at this point in time, what we've had is an effort to. I think the paradigm in myeloma has been continuous treatment with a maintenance drug. So sometimes that's most of the time that's single agent lenalidomide in some situations, or Revlimid in some situations. Single agent bortezomib or Velcade can be used in a less frequent schedule than it was given at the start of treatment. We found largely that, at least in the United States, our efforts have been to continuously use Revlimid maintenance until time of progression. So there's not been a defined period of time where we stop. That practice is based on a big study, or several big studies that for which there was a pooled analysis and led by Dr. McCarthy from Roswell Park. So they pulled 3 big studies of Revlimid maintenance where they compared Revlimid to placebo or Revlimid to observation. Each of those studies suggested that Revlimid helped delay the amount of time until patients had a relapse. That pooled analysis found that there was a survival benefit towards being on indefinite Revlimid maintenance. And so that study has changed, I think, some of the practice towards really extending the duration of the lenalidomide maintenance until time of progression. So there is not at this point in time a defined period where we would say one should get maintenance for 2 years and then stop, or 3 years, or 4 or 5 or 6. So really we give it until time of progression. Now, there are some downsides to this. So Revlimid has side effects, fatigue, people can get diarrhea caused by this bile acid malabsorption that can be treated with some bile acid binders, but it's a quality of life thing. And most patients can continue Revlimid. We don't have, with dose adjustments and modifications that allow for management of side effects, most patients can do it indefinitely. There's a small risk of developing second cancers that has been associated with Revlimid, such as leukemias and other types of malignancies. So This seems to be a very small percentage of patients, but is a real issue and is a real downside towards the counterpoint towards indefinite Revlimid. We think because of the survival benefit overall for patients as a group that we do still recommend indefinite Revlimid maintenance for everybody, because on the whole, we think we're extending myeloma patients' lifespan. There's a small number of patients who do develop these second cancers, which is a real issue, but doesn't affect a lot of people. It's very hard when that happens, but it's something that we take very seriously in our discussions. So getting to the other downsides. So I think we're sort of blanket treating everybody until time of progression. There may be some patients that we are over treating with this approach. How do we identify those patients? So many of the questions that were asked, like, can we stop maintenance after a certain period of time in some patients? How do we assess them? There's an ongoing trial that we're involved in at U of M. That's a big national trial called S1803, or the Southwest Oncology Group is leading that. Essentially it asks two questions. Is daratumumab, a monoclonal antibody for myeloma, plus Revlimid better than Revlimid alone? So patients are randomized to either get two drugs or one drug as maintenance. And then after 2 years, there's a bone marrow-based minimal residual disease test where we look for any leftover amounts of myeloma at that point in time. If you have leftover amounts of myeloma, or if there's anything detectable, you continue maintenance and you don't stop. In that study, in those patients who don't have leftover myeloma at the 2-year mark in the bone marrow-based MRD test, patients are being randomized to either continue maintenance or stop. We're probably going to not have the results for this trial for like 7 to 10 years. So it's going to be a long time before we get the results to say, could we, in the patients who have a superior response to myeloma who are MRD negative, could we discontinue maintenance in some of those patients? We might be able to, but I think at this point in time, it's still a research question. There were some interesting abstracts from ASH, not this year, but last year, that looked at trying to see in some of our patients on maintenance, could you use MRD testing to decide to continue maintenance? Now, these are not randomized trials, they're smaller phase 2 trials, so smaller number of patients. The important part of that, like what's the difference, is in a phase 3 trial, you can prove statistically that something is better than something else, and that's the goal, because you're comparing the control group. In a phase 2 trial, you've got a single group of patients, so you can report what you see, but it doesn't definitively answer the question. So they used MRD testing to discontinue maintenance of people who are MRD negative and reported, some of the findings of like how many of them progress or how many, and it seems like in those people who are MRD negative, the rates of progression were small. But I think at this point in time, I really think that the discontinuation of maintenance it's a tough question. I usually recommend people try to continue maintenance until time of progression. There are some exceptional circumstances where I've talked with patients about doing some testing of their bone marrow, and if there's something going on where they really need to stop, and we want to know, is there leftover myeloma in the bone marrow, and that's really a very small handful of times where that's come up in my practice. I think that we'll hopefully learn some more from these randomized trials about whether we could discontinue maintenance to some of these patients. The last part of this question that was asked that I want to address is, can you use blood-based testing to replace bone marrow-based MRD testing? So I think this is a really interesting area of research. So far, to my knowledge, the blood-based minimal residual disease testing with sequencing has not matched what's in the bone marrow. There have been some preliminary studies looking at the use of another tool that can detect tiny monoclonal proteins, and this is a tool called mass spectrometry. There are some specialized centers in the country that have access to this type of laboratory equipment, Mayo Clinic, Memorial Sloan Kettering. This type of test is not, I think, regularly widely available. It could be another method to assess minimal amounts of myeloma that could be done peripherally. But at this point in time, I don't think the state of the science says that we could just skip the bone marrow and do the peripheral blood testing. But as the use of mass spectrometry, or mass spec as it's called, advances, and maybe we'll learn some more information about the sequencing-based MRD testing or other changes to that method that could allow for this in the future. But at this point in time, my understanding is that the blood-based MRD testing doesn't match what's in the bone marrow with high enough reliability to say that we could exclude doing the marrow, unfortunately. I really wish we could. Maybe can I take the next question?
Joanne, do you want to unmute and ask your question?
Yeah, so I wanted to go back to the gut health. So we all know that antibiotics, oral antibiotics really kill your gut health. They really do a number on your stomach. And after a course of antibiotics, I wanted to take some probiotics to restore my gut health and not have to wait, for it to do it naturally. And I was told by my team, I'm a patient of Dr. Campanero's, that it wasn't safe for me to take probiotics. So why is it not safe? And like, how are we supposed to restore our gut health, naturally without being able to take some probiotics?
Yeah, it's a great question. So, I think it gets, back to, how can we impact our gut microbes if they might be important? And, especially after a course of antibiotics, which could be for a very important reason, and it's probably not optional. You just, sometimes you can't avoid, right? You need antibiotics are life-saving. So sometimes you need to have them. So I think that probiotics, I think, are another area of great controversy. I think the dietary supplement industry doesn't have the same type of quality control requirements, so that say what is in the product actually matches what's on the bottle. So the FDA doesn't regulate dietary supplements. Most probiotics fall under a dietary supplement category. So I think that partly one of the questions is there's several questions, like, is for a given probiotic, is like what's on the bottle actually what's in the capsules? Second question, that is that proven? Can taking probiotics really impact the content of the gut microbiome? So if you introduce like a small group of bacteria through a capsule, like if you're trying to influence an overall big population of bacteria, does that make an impact? I think is another question. I think the safety, questions are I think unknown. I think probably there's some. I'm struggling to recall the most common probiotic that I see. It may be a line. I think it's the one that I've probably seen it in use most often. Not for my recommendation, but just for what I've seen on people's medication lists. I think that trying to there are some foods that have some bacterial products in it. So yogurts, sauerkraut, some fermented foods, those, are I think are safe. So I'd say that, products with dietary fiber, maybe some of those types of foods might be useful in contributing to, gut health. So
they told me not to drink kefir because I was going to drink some kefir, and they said, don't even do that.
Yeah. I think that there's probably, I think it just may be kind of maybe unknown to that team. I guess like would I tell a patient not to drink kefir? I think it kind of I don't necessarily have access to kind of all the information. Not sure if you were neutropenic at the time. I think that probably I would be more cautious if someone's neutrophil counts were low. And I think it may have come from a place of just wanting to take the most precautions, just given that there's some unknowns as to like what would be included in those things. But I think it's it's a great question. I think it's something that I think we need more information about and like better studies to evaluate it. Thank you for the question. Yeah,
Thank you.
question from Jerry Roth in the
I've
room.
been on Pomalyst and Darzalex for over 3 years, and following my stem cell transplant, Dr. Anad's team said that they would not administer the MMR vaccine because of what I'm taking.
Why?
With the interest in measles lately, is there a plan that could be instituted that would allow patients like myself to get the MMR vaccine?
That's an important question. So, I think especially with decreased, use of vaccines like the MMR vaccine in the general population, we're seeing some, small case outbreaks of measles, and there was one in our community here, which is it's really unfortunate. So, there is not, I think, a overall plan to be able to administer MMR to patients. Really live vaccines carry risks for patients that have immune compromise, because it's a weakened virus they're administering, but it could actually proliferate in a patient who doesn't have a completely intact immune system, and those drugs could certainly affect it. So one can get if immune compromised patients, there are cases where people have had I believe immune compromised conditions and have had a vaccine related illness from a live virus. So I guess like that's probably the problem. So there has been a study on this to a small degree. So I think the Dana-Farber group looked at patients who a couple years out from their auto transplants, and it's been a couple years since I read the paper, so forgive me for not knowing all the details. But what we had is, I think at like 2 years, they had a small group of patients that were either on lenalidomide single agent or were potentially off maintenance at that point in time, and were able to get the MMR vaccine, and they reported outcomes from that. And to my recollection of that paper, which I'll need to go, kind of re-review again, given the recent current events here, there were not a lot of adverse events or negative impacts from the MMR use in that patient group. Now, for your specific situation, it's harder, because I think if you're currently on Darzalex and pomalidomide, I think that's a different scenario. And I think it's hard to comment, on whether or not that would be safe for you. I kind of would be a little worried about using an MMR vaccine. So are there any other approaches? I am not aware of other preventative approaches that one can take besides live vaccines, other than just like taking some general precautions. But the problem is measles can be quite infectious, so it's really hard to know, to be able to take precautions, I think. So
I raised the question at a prior Ask the Doctor breakfast, with the doctor at that time said, well, maybe if you were off Darzalex and Pomalyst for 2 or 3 months, it would be okay. That was the end of the discussion.
yeah.
Yeah.
Yeah, it is similar, like I think there's not enough data to say there'd be a reliable plan for doing it, and I think the full depth of knowledge of like the risks, I think, are unknown. So it would be kind of a
I guess that's why Dr. Campanaro hasn't answered my question.
could be, yes. All right, yes, Nancy.
We talk about MGUS and multiple myeloma and active. Are there any tests or things that our primary care physicians would look at prior to MGUS? Is there some blood work that would trigger something for them? Are they that knowledgeable, or they just see something and say, maybe you need to go have further testing? I just think it's all of a sudden you have MGUS. Well, where did that come from? Did they see it before, or did they not notice it?
Great question. So this again touches on kind of the precursor diseases to myeloma and how those are found. So currently, most of the precursor conditions are really found by accident. So there's some other problem that's going on, maybe a kidney problem or a neuropathy problem, or maybe a little bit of anemia or some issue that led to a doctor to order a protein electrophoresis test, which could detect a monoclonal protein and lead to a diagnosis of MGUS. Excuse me. So what I'll say is currently there's no method for screening, or there's no, I say guidelines for screening. So unlike for colorectal cancer or, prostate cancer or breast cancer, there's no guidelines to say that everybody should get a protein electrophoresis test at a certain age. There's not, I think, enough data about that yet to say that, what would we do with that information? Probably would, we know that our rates of finding something go up by age. So, 3% of the patients over 3% of people over the age of 50 probably have a monoclonal protein, whether they know it or not. And that number goes up by age. That's based on some studies from Mayo Clinic, where they went out in their community around Mayo and just did protein electrophoresis on everybody. There was a really interesting study that's in progress now called the iStop-MM trial, which is based in Iceland. And so this is a really remarkable study. I'd encourage you guys to Google it and look it up. But what they did was they wanted to explore whether or not on a population basis they could do screening for plasma cell disorders. So the eligible people were anyone who lives in Iceland who was born before 1975. They had, I think, 180,000, I want to say, eligible people, and I think they enrolled like half the population in like 6 months, which was like remarkable. And so there's a whole effort to like collect blood samples from all over the country, send it to a central lab to do everything, in a consistent way, to check the protein electrophoresis and the free light chains. And this, I think, has led to a bunch of interesting findings. Impacting the normal reference ranges for some of the blood tests, like the free light chains, those are potentially going to need some adjustment based on prior testing. There's now a risk model that I use in regular practice to help me decide which MGUS patients I should get a bone marrow biopsy in, and which MGUS patients I may be able to skip a bone marrow biopsy in. So I can put in the patient's lab test information. It'll tell me what's the % chance that they will have smoldering myeloma, at least marked by 10% or more plasma cells. But this study will eventually, tell us some information about how closely we need to follow patients and might impact whether or not we do screening for this in the future. So in general, I think there's not a test that one would send before the protein electrophoresis. I think that it would be a situation that would depend on like what other reasons were around for sending it in the first place for a given patient and physician. So I think we are often, seeing protein electrophoresis results that are indeterminate, and we work through those routinely in the clinic, and we deal with finding, trying to sort out whether people have MGUS or smoldering myeloma quite frequently. But there's not, I think, a routine test that one could send before MGUS. It likely, in some patients who have developed myeloma, they found sometimes that even the monoclonal gammopathy could be detected many, many years before they ever develop anything detectable. So some studies, big longitudinal trials where they collect samples for patients over like decades were done, largely around the NIH. And some of those patients who developed myeloma later, they went back and looked at some of their old samples and actually found M proteins like decades before they had myeloma. So it's likely something that starts, maybe in our 30s or 40s even, and for those affected individuals. But we don't routinely check, and I think what's the downside of checking? You're seeing a doctor every year, you're getting these blood tests that are causing anxiety. The overall rate of progression to myeloma in MGUS patients is low. So in those patients in whom we do know about MGUS, I think following it is worthwhile, because we find that if we follow patients compared with not following patients who have MGUS, the rates of developing harm from myeloma are higher in the MGUS patients who aren't followed. And I think that makes sense. If you're watching higher likelihood of identifying a problem before it becomes a problem and starting some treatment. Or, limiting harm, where if you're not looking for trouble and trouble shows up, you could have more trouble. So I think it makes sense to follow the patients that we know about, but I think there's still a lot of data that we need to find out about screening. The other trial relevant to screening, the PROMISE study is based out of Dana-Farber, and so this is for patients who have either I think over the age of 30 or 40, and if you're African American, because the incidence of plasma cell disorders is twice as common in African Americans compared with other ethnic groups, or if you have a first-degree family member who has myeloma, can sign up online to potentially get screening done through Dana-Farber. So it's all through this website, and if there's any interest in that, I encourage you guys to look at that online.
Well, part of the solution is to raise the awareness of multiple myeloma in the general medical community, with the primary care physicians.
Yeah, that's been important too. A couple of years ago, I gave a talk to some of our general medicine department, to our general medicine docs at U of M on protein electrophoresis and the testing, and doing trying to work on some of this education. I think there could definitely be, opportunities for learning, medical education initiatives to try to help docs know what to do with some of these labs and some of this testing.
Nancy has a question. She says, my understanding is that Revlimid is not for people with kidney or liver issues. Is there a substitute?
Revlimid needs to be used carefully in patients with kidney disease. So Revlimid is not harmful to the kidneys, but Revlimid is cleared by the kidneys. So if the kidneys are not working well, the byproducts and breakdown products of Revlimid and the side effects of Revlimid may be greater for the same dose. So we can use Revlimid in patients with even very advanced kidney disease. We just have to make the dose very, very low. So even in patients with dialysis who have basically no kidney function, we can use Revlimid. Or patients with very, severe kidney failure, we can use Revlimid eventually. Sometimes we want the kidney function to be stable, so that the clearance is kind of reliable. And many times if patients are newly diagnosed with myeloma and they develop kidney injury and they're in the hospital, there are a variety of reasons why we may not immediately start with Revlimid. It takes a little bit of time to get Revlimid. You need to get insurance authorization. It might need to come from an outpatient pharmacy, and there's some just like time issues for getting Revlimid right away that might be early barriers to getting Revlimid. But once patient's been in the outpatient setting, we can generally put a patient even with advanced kidney disease on Revlimid. Additionally, I don't know that Revlimid is harmful to patients with liver disease. So I've not really had too much to deal with patients with mild degrees of liver dysfunction. I would just encourage you to discuss with your physician if that's relevant about kind of what the management might be. But really, I think the Revlimid does not impact the kidney function negatively. It just needs to be used more carefully in patients with kidney disease.
We have another question. Robert asks, at first relapse where SCT has not been done previously yet harvested, is it still recommended to do an SCT at 5 years since MRD? It seems that CAR T-cell treatment might be more effective after a DARA treatment is doing SCT at 5 years out.
This is a great question. Based on some of the determination study results evaluating early versus delayed transplant, we found that there are situations in which patients can potentially defer transplant as part of their initial myeloma treatment. We know that transplant seems to delay the amount of time until first relapse. by about 21 months on average in that study over the patients who didn't get transplant at that time. So at first relapse, I think the issue is it's a little bit less, I think, clear as to like what, you know, is going to be if a stem cell transplant will be the best next indicated therapy. I think having a way to clearly study this, I think is difficult to know like what's the best next step, given that there's a lot of new tools in the toolbox. So relevant to the mention of CAR T cells, which for those who are unaware are these new way to treat myeloma that includes modification of our own immune cells that fight cancer called T cells to insert a gene module that makes them into heat-seeking missiles for myeloma. And they find this, they're going to go after this immune protein that's on the myeloma cell surface, and essentially the cells are taken from the patient, shipped off to one of the companies that manufactures CAR T cells. There are 2 companies currently that FDA approved products for CAR T cells for patients who've had relapsed myeloma with at least 4 prior lines of treatment, so pretty heavily relapsed patients. And that is a method with which myeloma could be used for sort of late relapses. Now, relevant to the discussion of like maybe early on, there are a couple trials that have been done using these CAR T cells in patients with earlier relapsed myeloma, so maybe 1 to 3 prior types of treatment. There was the CARTITUDE-4 trial, which is sponsored by Janssen, looking at their product called CARVYKTI versus some standard myeloma regimens. And then there's a very similar trial done using Bristol Myers Squibb's product, Abecma, compared with some of the standard regimens that are available to patients with myeloma with early relapse. Both of those trials had positive results and actually very pertinent and timely. Today and tomorrow, the FDA is holding some oncology drug advisory committee meetings where there are panels of oncologists who review all the clinical trial data, and then will provide recommendations to the FDA on whether or not there might be FDA approvals for these products in earlier lines of therapy. So based on the outcomes of some of these meetings, it is possible that CAR T cells may become available in an earlier line of therapy. How long to that? I don't know. That's something that's not, I think, clear. But there are drug applications that have been submitted by the manufacturers of these 2 products to try to get their product approved in an earlier line of therapy and provide access to patients in an earlier state of relapse compared with later. So that's some fascinating information to come. I think that would impact the answer to this question. So currently, in an earlier line of therapy, CAR T cells wouldn't be available except through a clinical trial. So I think that the direct, choice or question about whether or not one could get CAR T cells, with 1 prior line of therapy currently, unless someone were entering a trial that looked specifically at that patient population, one wouldn't be able to get it today. Whether that'll be the same in 6 months, I don't know. I think that the CAR T cells are exciting. I think they have very interesting mode of action, and I think the outcomes look like people are having good responses to CAR T cells. And I think one of the questions is, how might it look earlier? What's the comparison to stem cell transplant is often a question that we get. I think it's hard. I think there are different treatments, there are different tools, they have different impacts. I think that many times the stem cells that are collected as part of initial therapy are frozen and can remain viable for probably about 10 years. I would just, probably each decision about whether or not to use a stem cell transplant in the second line of therapy after some other type of treatment, such as Dara-Pom-Dex or daratumumab, carfilzomib Dex, or one of the usual regimens we consider in first line of therapy might be thought about. There's also some clinical trials that we're involved in looking at some of the bispecific antibodies in earlier lines of therapy. So trying to use some of these drugs which help grab the T cells in a patient and bring them close to the myeloma and cause the T cells to fight the myeloma cells. And they work very similarly they have similar side effects to CAR T, but it's more of an off-the-shelf product. You know, I think there's a lot of comparison happening between some of the CAR T cells and some of these bispecific antibodies. There are pros and cons to each approach. I think there's a lot more to learn, and I think there's some patient-specific information that would be relevant towards helping us figure out which way we would want to go with some of that. But that's, I think, another area that's been very
Robert
interesting.
thanks you. He says that he thanks you for your very thoughtful answer and it's very timely to his situation. So we're at our hour. Is there any last questions for Dr. Pianko before we close our meeting? And as you're thinking about what that question might be, if you have one, I just want to take a moment to thank Beijing for coming today. We have one of the reps from Beijing. Okay, thank you. And also Bristol Myers Squibb's here today, and virtually we have Santa Fe here today too. So without the generous support of our industry partners, you know, it'd be hard to put on an event like this. So we thank them for their generosity. And to Dr. Pianko, thank you very much for your time today. Is there any closing questions?
Thank you all very much for a really great discussion with great questions, and would love to come back and do one of these again. So
We hope to have you at the Wine and Dine in the day on November 6th.
Oh, great.
To participate on that panel would be an awesome thing to close out our year.
Wonderful. It's always a fun event. So
You're not having
thanks.
any babies during that time, right?
No.
They're done in the
that-
summer.
Yeah.
won't have it conflict directly with the Wine Dine and yes, like prior years. Yeah. Well, thank you, everybody. Have a great day, and you know, feel free to reach out to me if you have any questions or concerns. I'd be happy to answer any questions from anyone in the community about really anything. So feel free to reach out. Thanks again for joining and all the discussions.
Thank you.